Hello, everyone, and welcome to class number 4, pre-rounding and presenting on rounds. I'm Jared Dashevsky. I'm founder and creator of Healthcare Huddle, and I'm creator of this course, Intern Year Bootcamp, in partnership with Doximity. In today's class, we'll be talking about the pre-rounding process and how to present on rounds. Pre-rounding and rounding, more specifically presenting on rounds, are key bottlenecks in your day. Because if you are slow and inefficient at pre-rounding, and if you are slow and not effective at presenting patients, your morning will be dragged on. And you'll have an attending who looks annoyed, and you'll have a senior resident who's just doing this or tapping the leg or tapping their pen, right? They just want you to move along, okay? So this class could be the most important class in the course because it's a key bottleneck, right? And a bottleneck is, right, the toll booth on the highway is where things can get backed up pretty quickly. And I'll start with some housekeeping and some definitions. So pre-rounding and rounding. So pre-rounding is this process before rounds. So say rounds start at 8 a.m. sharp. Pre-rounding is the time here between rounding and when you arrive, right? So an hour and 30 minutes is what you have to review overnight events for the patient via the sign out from class number 2, I believe. You're reviewing vitals, reviewing objective data like labs, you're reviewing imaging, you're reviewing consult notes, progress notes, nursing notes, right? You're just consolidating all that information very quickly, okay? And I'll show you how I keep track of these things using like pen and paper, going back to class number 3. But this is your time to see every patient, to look at all their labs, objective data, do physical exams, attend to sick patients. And then rounding, hopefully, in under 2 hours, right? And when you're rounding, depending on the attending, you may bedside round where you're presenting the patient and you're presenting the patient in front of them or outside the room, and then you all go in together to do physical exams, or you're table rounding where everyone's just sitting around a table or on chairs and you're just talking about each patient, okay? But again, there is this risk that if you're inefficient with this, that rounds get prolonged, which is what we always want to avoid, and is what I avoid. So this is like off topic, but as a senior resident, so maybe you'll do this as a senior resident, before each new block, I will send an email to the intern I'm working with, and I'll just set expectations, talking about how to pre-round and round efficiently, effectively, what to be reporting on, how to escalate if a patient is sick, just so that they know how to streamline their day. And then before getting into the meat of things, I will just say the rounding is really for you as the intern and for the resident. The attending, they know what's going on with each patient. They know the plan, right? They already know, right? They're there for you. And so as an intern, your job throughout intern year is to get incredibly good at gathering data, synthesizing data, and then towards the end of residence or intern year, you're the one who's creating the plan and dictating next steps, right? At the beginning of intern year, you'll have a resident who's helping guide you, but by the end of intern year, you'll be that guy, right, or gal. But just keep that in mind, right? When you're getting frustrated with pre-rounding and rounding, it's really for you. The attending knows everything that's going on. It's for you, okay? So if you think about class number 2, where you're getting sign out, the main thing you need to recall are the overnight events. And if you remember what I was saying, right, key overnight events is a patient who had sepsis and was given fluids and antibiotics. Key overnight events is a patient who was hyper K with EKG changes. Not a patient with a magnesium of 1.9. Not a patient who is nauseous. These are key overnight events. And then subjective data you'll get and gather either through notes or through bedside rounding, right? But what I do is I will get sign out from the night team. And remember, this is class number 2. where I discuss that. And then after getting sign out, I'll print out my list, and then I'll start recording data. Again, the goal is to have a one-page list, right? So if we go back to my list from earlier, how do I keep track of things? Okay, in the location column, or in the first column, this is where I'll keep track of the overnight events, right? I'll just quickly drop like septic. And if for Draj dash, maybe I write hyper K. This is just to jog my memory, right? Your memory will get very good. So all you need is like little codes to help you recall. For Deborah Smith, let's say they had an episode of AFib RVR, right? This is what I'm writing in column 1. And then in the rest of this space, and like this space right here, is where I'll keep track of the data, and then this could be like the overflow area. But the way I keep track of data is using the skeleton method, which I highly suggest you do, right? So skeleton is this. Okay? You can look this up on your own, but real quick, this is like where you keep track of the hemoglobin. These are platelets, hematocrit, white blood cell, sodium, potassium, bicarb, chloride, creatinine, glucose, INR, AST, ALT, right? You'll use a skeleton method because it's too inefficient to go under each patient and do hemoglobin is 7 and write down white blood count is 12. Too inefficient, okay? So in the cases here, for Jared Dashevsky, he has pneumonia, right? So I only write down pertinent labs, right? So if white count is now 12, in parentheses, I always put in the last white count. So let's say it's 19, and maybe I'll add an arrow to let me know that it's downtrending. If I have not been trending hemoglobin, if it's been rock stable, I don't even write anything. And if the entire lab set, like a BMP, is stable and unremarkable, I'll just do this. Circle with a line through it means nothing. Nothing has changed. And that's it. Okay? For renal, right, this guy was hyper K overnight. So let's say his AM was 5, down from 6. So now on rounds, I'll be like, potassium T is 5, down from 6. And then everything else is stable. And I'll just continue that for each patient. And then for imaging, you can do what you want, but sometimes I'll just do chest x-ray just to remind myself that the patient got a chest x-ray, and usually I remember the results. But if not, a fun trick I learned, or an attending taught me, was to basically draw your imaging findings. So if this is a chest x-ray and these are each lung field, this is the right, left, if there's pneumonia, you can do that, and you could be like consolidation in the left lower lobe, right? So you're drawing it out, and that definitely helps you remember it more. If you have an EKG, you could just write down normal sinus rhythm, something like that. Okay, quick. And you do this for each patient very quickly. Oh, and one thing I forgot to include is, where do you put the vitals? I usually put the vitals under the overnight events. So if all the vitals are stable, I do this. But if they're AFib RVR, I may give a range. So let's say 100 to 150, and blood pressure underneath. But if the blood pressure was normal, I'll again just do a circle with a line through it. Tell me the vitals were stable. I don't typically write down the physical exam findings, right? Because if your memory will it's just so much better when you're actually doing the physical exam, that you could close your eyes, think, what was Jared Dashevsky? Oh, he had this crackles in the left lower lobe, which makes sense because this patient had a consolidation or something in the left lower lobe, right? So physical exam is what I remember. I will say, don't make up your physical exam findings, right? If a physical exam is unchanged compared to yesterday, you can say that, but make sure you actually examine the patient and it's unchanged. You don't want to be in the situation where a patient has crackles throughout both lung fields and they are remitted for fluid overload and they were improved yesterday, but now they're worse, right? You don't want to be caught in that situation. And if you don't examine the patient, be like, did not examine the patient, but he was breathing well in room air, no acute stress. That's okay, right? Just be honest. Don't make assumptions. And so this is the pre-rounding process. And like I said, when you start rounding, you're going in either like this order or reverse order. You don't want to backtrack. Backtracking is very inefficient. So start on 9 West 5B, see all the patients on 9 West, go up the stairs, go to 10 West, then after 10 West, you cross over to 10 East, and then go up to 11 East. Some hospitals are not geographic. Like the one where I train at, not geographic, so you're really running all over the place while you're rounding. What else do I want to say? You will inevitably have a crashing patient while you are pre-rounding, right? Before you even round anyone, and that is okay, right? You need to do what touches the patient first, right? If Rebecca Smith, as I said in the last video, if they are crashing, you are seeing Rebecca Smith first, and you're making sure she is tucked in before you leave to see other patients. And that's when you'll text your senior resident to help out. And it's totally understandable, totally okay if you can't get to the other patients because you're dealing with a crashing patient. That is totally okay. And that's really the pre-rounding process. And remember, here is where I'm keeping the to-dos or the assessment and plan for each patient and what we're actually doing. And then if anything comes up in the interim where I need to keep track of to-dos, right, it's going in that folded side of the sheet. Let's talk about rounding. When you were a medical student, the expectation was that you round in a very you present in a very systematic way. Overnight events, or maybe you do a one-liner, overnight events, subjective data, objective data, assessment and plan. And you go in that order and you take your time, you talk about every single detail. At the start of intern year, please do that, right? Because you want to learn it right first and get the routine down. But as you advance, as you do more rotations, it should become more like clockwork. Like it should get much easier. So on the first day of the rotation, I usually am totally okay as the senior resident with you giving the one-liner for each and every patient. And then after that first day, we kind of all know the patients then. We've all seen them. We all know what's going on. And then you can drop the one-liner and just talk about overnight events, subjective data, objective data, assessment and plan. Everything you're presenting should be high yield information. Again, don't report that Jared Dashevsky was nauseous overnight and got Zofran. That's not so important unless they have like a prolonged QTC and we've been monitoring it and you just need to let someone know that they got Zofran. That's important. But for someone with CAP who's on ceftriaxone and Zithro, I don't need to know that they got Zofran. What I do need to know is that they were septic overnight, right? So let's say Jared Dashevsky, here's how I would present him. This 30-year-old man with hypertension, hyperlipidemia, presenting with CAP and found to be altered. He's been treated with ceftriaxone and zithromycin and high-flow while he's been here. Overnight, the patient, even though I said no overnight events, let's say patient was febrile and hypotensive. Blood cultures were performed. He got a liter of fluids. We brought in antibiotics from ceftriaxone to cefepime and vancomycin pending MRSA swab. Vital-wise, he's now a febrile down from 101. Heart rate is 90 down from 110. Blood pressure normal. That's the vitals. And then you go into physical exam. Physical exam, patient in no acute distress. Cardiac exam unremarkable. Lung exam shows crackles in the left lower lung fields or decreased breath sounds, worse compared to the day prior. Extremities are warm and well perfused. CAP refill is less than 2, showing that he's adequately resuscitated. Lab-wise, white blood count is 12 down from 19. Everything else remarkable. BMP unremarkable. Chest X-ray showed a worsening left lower lobe consolidation. KG normal sinus rhythm. Plan for Mr. Dashevsky, 30-year-old with hypertension, hyperlipidemia, CAP, AMS, now resolved, but with breakthrough fever, concern for poor antibiotic coverage or inadequate antibiotic coverage. So plan for him. For CAP, we brought in cefepime and vancomycin, follow up the MRSA swab, continue with high-flow nasal cannula. Monitor blood pressure, right? Something like that. Very short and sweet, only the high-yield information. You're not, for the labs, you're not saying hemoglobin was 10, stable. Platelets were this, stable. Sodium, this, right? No. Only say the labs you are currently trending and any dramatic changes. And you'll do that for each patient. Nowadays that we all have the electronic health record electronic health records app, like on our phone, right? Like Epic has HiQ. It's very easy to read off of the phone. I'm kind of, even though I'm a pro technology, pro AI, I will say try to limit your technology use on rounds because you will only become more unorganized and sound more disorganized. Okay. I love writing things down because everything I need to know is already written on the paper. So I literally just have to look at the paper and I can look up at people, look down, look up. The assessment plan is already there. Everything is there. I don't need to tap and flip through the phone. That's just my advice. You may find a better, more efficient way, but I think writing things down is efficient and effective in the long run. But hypothetically, let's say you saw Jared Dashevsky in his room on 9 West 5B, noticed that he wasn't looking too good, and you want to know which antibiotics to broaden him to, right? And your senior resident isn't there, so you're on your own. What can you do? Well, you can open up Doximity Ask and quickly see what antibiotics would be recommended to broaden to. So let me show you. So when you're outside of the room or even in the room, you can quickly ask via the microphone or type in your question, right? And Ask will tell you the answer within seconds. So let's say, what should I broaden antibiotics to for CAP in 30-year-old male presenting with CAP plus AMS, was getting better on ceftriaxone plus azithro, still on high-flow cannula, day 3, now recurrent sepsis, right? So let's see what it recommends. So recurrent sepsis on day 3 of ceftriaxone and azithromycin for severe CAP, AMS, which suggests, resistant organism or complication like an empyema or abscess. Remember, we saw that left lower lobe consolidation. So focus on adding MRSA and Pseudomonas coverage, right? Cefepime Vanc or Zocin Vanc. And here, this will tell you the dosing, which is great. Immediate antibiotic recommendation, which we know the Knight team did. And then for diagnosis, what should we do? We got blood cultures, they did a repeat chest x-ray. Maybe we do a CT scan to check for that empyema. Alternative considerations, what to avoid. Follow-up. Simple. And if you want to see the evidence or the guidelines, you can click throughout. And that's a quick, efficient way. Within a minute, you have your answer, or at least have some support of what you should do. All right. So that was class 4. Again, that's the bottleneck. Pre-rounding and presenting. Key bottlenecks. But hopefully with the expectations I set and the process I laid out for you, you'll be efficient. Again, it takes time. You're not going to be a rock star at first, but by the end of intern year, it will be boom, 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 boom. Right? You may not even need a list. You may just know everything about the patient. I'm telling you. You'll see. See you in class number 5.